Tracy Frech serves as the director of the Systemic Sclerosis Clinic at the University of Utah Hospital and the director of clinical trials for the Division of Rheumatology. She is also an associate professor of medicine in rheumatology and immunology at Vanderbilt University. Her research interests include the vascular aspects of autoimmune disease, primarily vascular leak and systemic sclerosis. Dr. Frech has published over 100 articles in peer-reviewed journals and several book chapters. She provides mentorship to medical students with a focus on improving their early research experiences. Now, I'll hand it over to Dr. Frech. Thank you.
Hello, and thank you very much for attending today. I will be speaking on understanding scleroderma vascular biology. I'd like to thank the Scleroderma Research Foundation for this invitation. My name is Tracy Frech, and I'm at Vanderbilt University Medical Center, where vascular biology is my research focus. I have no relevant financial disclosures or conflicts of interest. I will be mentioning pharmaceutical agents. I have no funding from any companies and have no stock in any of the companies of these pharmaceutical agents. So I have three objectives today. The first is I'd like to discuss systemic sclerosis as a vascular disease. To say vascular biology without describing how that fits into systemic sclerosis would not be appropriate. So we'll spend some time talking about making the diagnosis. We'll next discuss how the clinical features and longitudinal assessment for vascular manifestations is incredibly important for making thoughtful decisions in management of systemic sclerosis. And then I'll conclude on how a multidisciplinary collaborative team is critical, not only for patient management, but for rare disease research. So I'll start with a question, which is a bit of a trick question, in that what is the most common first disease manifestation of systemic sclerosis? Is this Raynaud's phenomenon, interstitial lung disease, or pulmonary hypertension? And the reason this is a bit of a trick question is when we use the term systemic sclerosis, that's different than the term scleroderma, that we tend to use this interchangeably. So when we use the term scleroderma, we're usually just referring both localized or skin-only scleroderma, as well as systemic scleroderma. And one of the key features of systemic scleroderma is that we have Raynaud's phenomenon. Both systemic scleroderma or localized scleroderma may have an ANA, and that's why patients are generally referred to rheumatology. However, when we use the term scleroderma, we more commonly talk about skin involvement or distribution. And I like this slide because it highlights the difficulties of using just skin fibrosis to define systemic sclerosis and localized scleroderma. When we talk about scleroderma, we tend to break it down to whether patients have sine scleroderma, so no skin involvement, or limited disease, where it's below the elbows, knees, and there's no abdominal involvement. However, patients certainly can change skin patterns over time and have atypical presentations. So what we tend to do in rheumatology more often to define this disease and help us understand how to monitor patients is to think about what that ANA pattern is and what is this scleroderma specific autoantibody. And because we're talking about vascular biology, I really want to highlight that these autoantibodies not only help us understand what type of skin involvement the patient's more apt to have, but it also helps us think through vascular involvement. So that RNA polymerase III antibody patient is at high risk for scleroderma renal crisis or gastric antral vascular ectasia, so two vascular manifestations that are important for us to recognize. So we may screen these patients more aggressively. And our limited centromere patients are at more risk for pulmonary hypertension. And so understanding that occurs later in disease becomes important. So when a rheumatologist is assessing a patient with a diagnosis of scleroderma, we're going to look specifically for vascular involvement and engage our other subspecialists appropriately in order to best understand vascular biology. However, in the absence of diagnostic criteria, we're going to really focus on those kind of three key parts of screening. Does this patient have Raynaud's phenomenon? Has that patient been screened for interstitial lung disease? And has that patient been screened for pulmonary hypertension? And again, in our localized scleroderma patients, those patients don't get these manifestations. So that's a different approach than our systemic scleroderma patients that do and really require aggressive screening in the context of their autoantibody. The first step for every rheumatologist when a diagnosis of systemic sclerosis is being entertained is that modified Rodnan skin score. And as we just talked about, what we're going to decide is whether this is limited disease or diffuse disease involving the chest, abdomen, thighs, and upper arms. And we do this, of course, by pinching the skin and saying, is there no involvement? Or do we think this mild, moderate, or severe involvement? And how is this changing over time? But I highlight that our classification criteria allow us to get to a classification of systemic sclerosis without skin fibrosis. And that really highlights these vascular manifestations of scleroderma, including the Raynaud's phenomenon with telangiectasias, digital tip lesions, and capillaroscopy. And if we look at those classification criteria over time and as a Venn diagram, you can see that most of our diagnostic or classification comes from the vasculopathy manifestations. And that really what we want to do is assess our patients early in disease course prior to fibrosis occurring. Because what we know is that scleroderma is a progressive small vessel vasculopathy that oftentimes starts with Raynaud's phenomenon. But when we think about systemic sclerosis, it's not the onset of Raynaud's, but the first non-Raynaud symptom that generally directs our treatment plan. So something happens between the Raynaud's and this dysregulation of the innate and adaptive immunity that leads to that fibrosis. And so we really want to be good rheumatologists. That clinical assessment is critical for us screening actively for vascular and fibrotic skin and internal organ involvement in the context of this disease duration, because we may see different things at different parts of the disease. And again, I highlight that pulmonary hypertension tends to be seen more in our limited skin manifestation patients later in their disease course, but can certainly occur earlier, and earlier diagnosis is important for applying therapeutics appropriately. Well, screening is an important concept, and the best screening guidelines we have is from this Lancet article authored by one of my mentors, Dr. Denton, in 2017, that really gave a good guideline for rheumatologists on how we should be actively screening when a patient has a diagnosis of systemic sclerosis. And I'd like to highlight here, because again, this is a vascular biology talk, that in this screening process, we can do a really good job of identifying vascular manifestations that require more aggressive treatment. So when we're doing our Doppler echocardiogram, our pulmonary function test, we're screening for pulmonary hypertension, which is diagnosed with that right heart cath, but we also get more data that may show primary cardiac involvement, irrespective of changes in the pulmonary artery. And if there's changes in the heart identified on echocardiogram and EKG, a blood test called a basic natriuretic peptide or a BNP or a cardiac MRI can be incredibly helpful for us understanding subtle vascular changes in systemic sclerosis. I also highlight that an important vascular screen that patients can do in their home is that blood pressure monitoring log that they should be doing a minimum of 3 times a week in order to identify risk of renal crisis. And that is particularly important in our patients with our RNA polymerase III antibody positivity, or if there's diffuse skin disease early in the course of the first 5 years of disease. This vascular screening, again, is done to identify patients that will benefit from therapeutics. So let's just take another minute to say, what are those measurement tools and what numbers as a patient should you be looking at? So your pulmonary function tests give you a couple of measurements. So when you do your pulmonary function test, you're sitting in this booth and you're breathing, and when you're breathing into this device, it's measuring how well you breathe oxygen out and what your total lung capacity is. And by measuring how well you exhale oxygen in the first second, as well as your total forced vital capacity, we can get some idea of restriction that can be indicative of interstitial lung disease. Now, when your provider's ordering your pulmonary function test, they're ordering spirometry, which is those measurements of oxygen blowing out and how well the volume of your lungs work. But they're also measuring the diffusion capacity. So the order should say spirometry with diffusion capacity. And diffusion capacity is how well the oxygen gets from the lung into the bloodstream. And so when we look at that diffusion capacity, if it's isolated only, your spirometry is normal, but your diffusion capacity is reduced, you should make sure you've talked to your physician about whether you've had your echocardiogram. So annual screening with an echocardiogram in systemic sclerosis is recommended. And if you have a diffusion capacity of less than 80, you really want to make sure that that has been done, and or there's been algorithms put in place looking at your basic natriuretic peptide and the ratio of different values on your spirometry and diffusion capacity, so that you get appropriately referred for a right heart cath. So a right heart cath, again, is how we're going to diagnose pulmonary arterial hypertension. And we'll speak to that in another slide here. But importantly, when you get your echocardiogram screen, there's different features of pulmonary arterial hypertension. And so the tricuspid regurgitant jet is the most common way to estimate whether there's pulmonary hypertension. But oftentimes, if that is not available, they can't get a true estimate. It might say that there was an insufficient jet to measure that regurgitation. There's some other clues that can be present that are important for you to discuss with your rheumatologist for referral for further diagnosis of pulmonary arterial hypertension. And that can be changes to the right atrium and the right ventricle if those are enlarged. Here's the atrium and ventricle. If those have bigger sizes, it's usually described as a dilatation or hypertrophy, meaning that the changes in the muscle. That really is important to have further diagnostics. If they're so large, they begin to compress the left ventricle, that's your pumping side of your heart. That can be important for a more urgent referral to the cardiologist. Certainly if there's a dilated pulmonary artery, and I always like to point out if there's any presence of a pericardial effusion, that's usually the last line on the echocardiogram report. That's really important for a scleroderma patient to know if that's present. And it's because it can be a poor prognostic sign if it's related to pulmonary arterial hypertension. And because the right pressure is impeding that pericardial drainage, this, unlike other types of pericardial effusions in rheumatic disease like lupus or sarcoid, where we may drain that pericardial effusion, in systemic sclerosis, we do not do this since the right ventricle is under high pressure. So it's an important sign to have evaluated more urgently by the cardiologist. And what they'll do is, if these echo signs are present, they'll do what's called a right heart catheterization. If there's concern about the left side of the heart, they may combine this with a left heart catheterization, but for pulmonary hypertension diagnostics, they need to do the right side of the heart. And what the right heart catheterization is they float this catheter and they give measurement of the right atrium, the right ventricle, the pulmonary artery pressure, and a pulmonary artery wedge pressure. And with these different measurements, they can classify what type of pulmonary hypertension you have. And if your pulmonary vascular resistance is high and the wedge pressure is low, this would be pre-capillary pulmonary hypertension or pulmonary arterial hypertension. And this benefits the most from our vasodilator therapy, which we'll talk through in another slide. But I'll pause there because when we talk about vascular biology, one of the things that can become confusing is vascular disease. So when we use the term vascular disease, we tend to all think of atherosclerosis. This is where a atherosclerotic plaque occurs on the luminal side of a blood vessel. This occurs with longstanding hypertension, fatty diet, obesity, diabetes, metabolic disorders. Normal vascular function has this nice thin endothelial cell lining, and there's not that pleasant presence of a plaque. And so when we think about vascular disease, we tend to think of large blood vessels, so the elastic arteries or the muscular arteries. But when we're thinking about systemic sclerosis vascular disease or vasculopathy, we're thinking about the endothelium, that vascular lining cell, independent of the presence of atherosclerosis. And these endothelium is changing in autoimmune disease, mostly because of blood vessel damage or dysfunction. While pulmonary arterial hypertension is a muscular large artery, when we use the term systemic sclerosis vasculopathy, we're really more referencing those smaller endothelial or capillary abnormalities that occur over time. And so this is why rheumatologists often have the first opportunity to recognize vascular disease and quantify it so that we can effectively think of application of therapeutics. So in a patient with Raynaud's phenomenon and puffy hands with an ANA and Scleroderma specific autoantibody and in capillaroscopy nail bed changes, this patient meets classification criteria for systemic sclerosis, irrespective if they have any other skin involvement with fibrosis, whether they have interstitial lung disease or pulmonary hypertension. So this would be an early patient with any evidence of end organ damage, with the exception of changes to their capillaries on their nail fold, seen at the base of their finger. And one of the challenges is if we take patients that look like this in the clinic, and here is an example of different patients listed here, and we look at different molecules of inflammation, we can find the challenge of treatment. So we have some patients that have no evidence of inflammation or immune dysfunction, and other patients that have lots of different molecules that are up that look quite inflamed. So in clinic, while they're looking the same, in the laboratory assessment, they're very different. And that would beg the question, how should a rheumatologist best treat systemic sclerosis if the answer is not immunosuppression, particularly in this patient BW? How should we think through therapeutics effectively in all comers with systemic sclerosis? So to answer this question, we turned to the research setting. And we decided that if genetic risk factors act before the clinical appearance of that tissue injury that propagates that autoimmunity or inflammation, how do we best think through this disease, again, that is characterized by vasculopathy, autoimmunity, and fibrosis? And what we did is we looked at a unique research tool called the Utah Population Database, which has over 7 million medical records, and it links the familial pedigrees that are available through the LDS or Mormon Church that can go back 11 different generations to health records. And what you can do is look for a condition, and in this case, we looked at systemic sclerosis, and we can look at how these different probands or patients are linked to each other with systemic sclerosis, and then you can calculate comparable heritability to pedigrees that are exactly the same but don't have any systemic sclerosis. So when you look at families with systemic sclerosis and you compare them to families without systemic sclerosis, and you look for the disease feature of Raynaud's, you find that in our systemic sclerosis pedigrees, first-degree relatives were 6 times more likely to have the presence of Raynaud's phenomenon, even if they didn't have, or without systemic sclerosis, and that extended to the second-degree relatives. When we looked at autoimmunity, and we defined that as rheumatoid arthritis and lupus, inflammatory myositis, all those conditions that are typically seen by rheumatologists, similarly, we see highest degree in first degree relatives, and then that extended out to second degree relatives, but less so than that diagnostic code of Raynaud's phenomenon. When we looked at interstitial lung disease, interestingly, this extended all the way to third degree relatives, but with less times degree likelihood than that Raynaud's phenomenon. So when we look at all this together, if we were trying to understand the genetics or predisposition to systemic sclerosis, certainly it seemed that Raynaud's phenomenon was an important understanding characteristic to do further research on. So what we then did is we did skin biopsies on systemic sclerosis patients and Raynaud's phenomenon patients, and we looked for some universal features in an objective and systemic manner using whole field digital microscopy and transmission electron microscopy. So what these two tools do is takes the human eye out of it and looks for features on histology with advanced staining for autophagosomes, which are presence, which we saw on electron microscopy and are present when there's oxidative stress present or the endothelial cell is under stress. And what we wanted to understand, if we biopsied normal or severe, what were these commonalities? And we found that regardless of disease duration or degree of skin thickening, there were endothelial cell abnormalities regardless. And those were not found in the healthy control population or Raynaud's patients. So something was different in a patient that had Raynaud's versus had systemic sclerosis, where that autoimmunity and fibrosis were playing more of a role. We also found that there were presence of perivascular mast cells. So there was the normal number of cells. There wasn't an increase in cells, but they were all located around the blood vessel. And there was swelling or edema that was present in all the systemic sclerosis specimens, but not in those healthy control specimens. And then autophagisms, as we already discussed, present in those patients with the electron microscopy. Well, that's where we turn and we say this is important research. This is showing the vascular biology of scleroderma, that there's a universal vascular lesion in systemic sclerosis patients, not present in Raynaud's patients, not present in healthy controls. But what is that? How does that translate into a systemic sclerosis patient? And we decided to really try to understand skin complications, particularly digital ulcers and extremity ulcerations, because they're painful in our patients, and we needed to do a better job with management. And I remind you that the etiology of different ulcerations can be different. They can be traumatic, or they can be due to calcium deposits as the blood vessel tries to repair itself, or they can be vascular in etiology, where pits or ulcers do occur because there's recurrent poor perfusion to those fingertips. Vascular digital ulcers do occur along a spectrum of Raynaud's severity. So we know that, again, someone may start with Raynaud's phenomenon, and as the disease progresses, it may be more severe in certain fingers, or it can come on relatively acutely with these black or necrotic digital lesions, and in particular, patients with long-standing disease, where there's poor perfusion, we can see more rapidly escalating findings that are obviously quite painful. And again, we want to prevent this spectrum from occurring. So what we wanted to understand is, if we take a patient that has Raynaud's phenomenon and a universal endothelial lesion on biopsy, can we use these non-invasive vascular measures to better characterize what's happening in systemic sclerosis? Can we characterize the vascular biology? And I'll take a moment to pause and thank the Veterans Affairs Medical Center and the NIH for sponsoring these serial projects. What we did is we developed or worked with teams to develop better patient-reported outcomes that capture the experience of Raynaud's phenomenon. We used nail-fold capillaroscopy, where we looked at the base of the finger over time, flow-mediated dilation, where we measured the blood flow, and we'll talk about this on the next slide, after occluding the cuff. We did the similar experiments with occluding the cuff and measuring temperature rebound, and which is called digital thermal monitoring. And last, we looked at sublingual capillaroscopy, where we measure the blood flow and function underneath the tongue in order to characterize what is happening to the blood vessels in systemic sclerosis patients over time. But first, let's talk about clinical capillaroscopy. Many of you might say that you have not had this done with a video microscopy, and that's because the training and certification is not available in the United States for nail-fold video capillaroscopy. We've worked quite hard with our European colleagues to develop dermatoscope findings of capillaroscopy as being an acceptable diagnostic screening test for systemic sclerosis. And we're working on a project with the Scleroderma Research Foundation in which we can apply artificial intelligence to better understand this qualitative reduction or fibrosis that occurs as blood vessels are lost, enlargement of the capillary diameter, hemorrhages, and abnormal shapes, to better not only diagnose scleroderma, but understand change over time. But one of the challenges of capillaroscopy is it gives the structural information, not functional information. And while you can look at structure over time to say, is this reversible, functional information is much more helpful for understanding the effects of our therapeutics. So what we ask the question is, we can certainly characterize our patient's capillaroscopy as being early, active, or late patterns, but can we then understand our therapeutics that we are using on how they are restoring blood flow, how they are working at the endothelial vessel cell level on transmitting the signal of shear to the different pathways we commonly use for pulmonary arterial hypertension therapies. And so we use the endothelial pathway in the form of ambrisentan, bosentan, and macitentan. We use that nitric oxide pathway in the form of riosquat, sildenafil, and tadalafil, and we use the prostacyclin analogs, epoprostenol, treprostinil, iloprost, and selexipag to try to improve blood flow to relax or vasodilate the smooth muscle with this thought that there's an anti-proliferative effect by vasodilating. However, we actually have never really understood or answered appropriately the question, do vascular-based therapies prevent fibrotic progression? And that, of course, is a hard experimental question because fibrotic progression assumes that you're predicting whose skin is going to get worse. So can we apply these vascular-based therapies early on and understand what patients do well in a preventative strategy? And again, we have these molecular pathways, the endothelium pathway, the nitric oxide pathway, the prostacyclin pathway, but we also use calcium channel blockers, and we have newer therapeutics looking at a TGF-beta ligand trap. Can we see how these different therapies act in our different patients with targeted vascular therapies, and then monitor how fibrosis changes both by skin score, those serial pulmonary function tests, and more importantly, with dynamic functional studies of vasculature to understand really how do our therapies impact patients. But I really pause there to say it's important not only to give therapies, but to review our patients' medications they're taking to make sure we're not actually causing harm with drugs and toxins that are associated with developing pulmonary arterial hypertension. So it's not enough to apply these therapeutics for vasodilators. We also have to review with our patients, particularly patients that have a lot of fatigue and may be on stimulants, for patients that may be undergoing cancer therapies, and for patients that may be taking supplements or over-the-counter agents, to really make sure that we're not missing an opportunity to withdraw therapies that may be causing fibrotic progression. And I will say, as someone who does a lot of needle caparoscopy, these medications do cause vascular damage, and if you take them away, the needle caparoscopy does improve. But again, caparoscopy is just a structural measure. So what we want to understand is function. And to do functional testing of blood vessels, what we did is in a human subjects laboratory, we prepare each of our subjects. They come in on a testing day. We look at the blood vessel size and flow through ultrasound probe in different experimental testing conditions. And so I'm going to talk through our first experiment of post-occlusive reactive hyperemia to show you what we understood about blood flow medications. So in this experiment, what we do is we measure through the brachial artery the vessel size and velocity. So you get two measurements. Then you occlude the blood pressure cuff, cutting off blood flow distal to the probe, and then you release the cuff and you measure how the endothelium is responding to that ischemic injury by the change in blood velocity and diameter. And with edge detection software, you can actually calculate the shear wall stress here and how well the blood vessel changes its size in response to that vascular occlusion. And taking into account to the initial diameter. So why that's important is it's comparing the subject to itself as opposed to a healthy control. And then you can look at those values between a healthy control and a scleroderma patient. And what was particularly interesting in our scleroderma population is our patients with digital ulcers, shown in red, had the lowest degree of forearm blood flow at baseline, the lowest response of peak hyperemia, and the lowest calculated flow media dilation percentage change in compared to the green patients were patients with digital pits, so history of digital ulcers, and then our yellow patient looked the most similar to our healthy control patient, and that they were able to have a more robust response of blood flow, peak hyperemia, and flow media dilated percent at that baseline measurement. But more importantly, we want to say, can we predict patients who are at risk for digital ulcers? So when we look at baseline flow, we see that in 70 systemic sclerosis patients, We could, at baseline, patients that have a baseline blood flow were more likely to develop digital ulcers. So if you get it one snapshot in time, baseline flow was certainly important as a variable of predicting developing digital ulcers. So what does that mean to you? That means that you should be on a medication to ensure you're having adequate baseline flow. Even if you don't have digital ulcers, even if you don't have a digital PID at this point in time, there is some data that would suggest that getting good baseline flow to your digits prevents a digital ulcer based on this functional assessment of systemic sclerosis patients. But then when we repeat that measurement, accounting for days between measurements and duration of systemic sclerosis, we find something that's really important in addition to, again, change in baseline flow. So if we were unsuccessful in giving enough vasodilator, those patients got ulcers. But that shear rate change was our most significant variable. And that shear rate change, again, is occurring on that luminal side of the blood vessel. Well, most of our medications are working to dilate smooth muscle. So that gives us a potential opportunity for understanding therapeutics that improve endothelial function by understanding what change over time in the endothelium does. So we asked the question, well, digital ulcers occur in patients with a reduced baseline blood flow and vessel response to shear. How can we understand whether that shear was because we did an experiment that occluded the blood vessel and released it? That's not quite what Raynaud's episode is, but it's similar. What about just not using a cuff occlusion and understanding shear rate of the blood vessel? So to do that experiment, we have to work to cause shear through a blood vessel without causing any occlusion. And so you can put an ultrasound probe at the femoral artery, and then you passively move the limb to create shear at that endothelial cell layer. And this gives us a novel way for determining nitric oxide-mediated vascular function. And what we found was really very interesting. Our control subjects were able to increase lower extremity blood flow more significantly than our systemic sclerosis patients, but that signal was really being driven by those patients that currently had a digital ulcer. But however, it wasn't that our systemic sclerosis patients that without digital ulcers were equal to controls. And when we look at baseline measurements in oxidative damage and the ability to have an antioxidant capacity, that was different in the bloodstream of our systemic sclerosis patients significantly to those healthy age-matched, sex-matched controls. So to kind of summarize vascular biology, systemic sclerosis patients have evidence of functional as well as structural differences in their blood vessels. Well, this is incredibly important, but some of the patients in the audience might be thinking, but I've been on oral therapies for skin ulcerations. I'm on all those vasodilators, and we still can't seem to get some of my ulcers healed. And what I really highlight here is the goal of a rheumatologist to work with a collaborative team. And so we all definitely need wound care professionals to help us remove devitalized tissue or devitalized tissue. And we also need to make sure we're proactively trying to understand if infection is present. So once we remove tissue that's not going to heal on its own and we treat infection, that really gives us two more options for improving wound healing. One is getting the right amount of moisture in that wound, and the second is to promote that healing edge within a wound so that you get that wound completely healed. And what we found is that even if we were optimizing vasodilatation therapeutic strategies, we still needed to pay attention to the dressings and promotion of healing through those dressings. And so we did experiments using amniotic membranes to place on digital ulcerations as well as lower extremity ulcers. And what we found really amazingly is these growth factors applied to a wound that was likely not getting enough perfusion because the blood vessels couldn't reach it. So we vasodilate, but we can't deliver the drugs that were being given orally. Supplementary growth factor dressings were very effective, both for pain relief and healing of these scleroderma skin wounds. We also did quite a bit of work trying to develop patient-reported outcomes that showed that the vasodilators were effective, because one of the real tragedies in the United States, as you may know, is that we don't have a lot of FDA-approved options for healing digital ulcers or vasodilators for Raynaud's phenomenon. And the reason is when the studies were done looking at patients with digital ulcers, they included patients that may have end-stage digital ulcers where blood flow was not going to get to that finger regardless of how much medication we were given. And what we have done, or we've learned, is that trying to get the right assessment tools into trying to understand therapeutic effects is necessary. And so there's a new questionnaire that allows that's rooted in the patient experience that allows us to get meaningful data on the patient experience with our vasodilators looked at. We also are doing some novel things with video microscopy on the skin. So this is not painful. The biopsy is not required, and we can visualize how how the blood vessel integrity is withheld and how well infection fighting cell counts, such as leukocytes, are getting through the wall. Why is that important? Again, we don't understand the immune system's role in the vasculopathy as showed by the serum test that we do. And so this novel tool can really allow us to try to dissect how much of this is the immune system and how much of this is vascular dysfunction. And I'm going to shift there to say this is a skin-based approach. But if we think about what is the patient's most important daily clinical complaint when you come to clinic, regardless of what type of scleroderma you have, it is actually not skin complaint. It is gastrointestinal complaint. And so we really wanted to understand, well, is the gastrointestinal tract disease actually just gut vasculopathy? And this is incredibly important and ties back to that digital ulcer. Actually, severe GI tract involvement is the most common internal organ manifestation that's associated with the skin manifestation of a digital ulcer. It can be a presenting feature of disease. It is common in all patients during the course of their disease. The literature cites 95%. This is 100% in my cohort. At one point, if you ask the questionnaire every visit, patients 100% of the time will complain of GI tract involvement. It can be a cause of mortality. And really interestingly, we know that there's this neurovascular communication that's a critical feature, and we have no way to study that in the clinical setting as a mechanism of action. And so this is a challenge for us. It can present differently in patients at different points of disease. It can be the first presenting feature or late feature. All patients get it. Doesn't matter what your skin involvement is. It doesn't matter what your autoantibody is. All patients have GI tract involvement, and it can precede laboratory abnormalities. Patients can be terribly symptomatic but have normal anatomy. We have patients with really abnormal patchless esophagus with no symptoms. And so the absence of symptoms does not exclude dysfunction, and therein lays the challenge of how do we study this? So if these patients are presenting so different with a diagnosis of systemic sclerosis, how as clinicians can we do a good job with the disease? And so we backed up and we said, okay, if this is a small vessel vasculopathy that results in dysregulation of innate and adaptive immunity and leads to fibrosis, let's think about that in the same way. What can endoscopy, biopsies, and manometry or other investigative tools tell us about the natural history of GI tract disease? And this is not an easy task because we have to first decide, how are we going to look at symptoms over time? Do we just want to ask patients, how are you doing today? Or do we want to use questionnaire severity? And what we most commonly use is this GI tract questionnaire. Here I put the link for you because it's no longer uniformly available without this unique link for you to kind of track your changes over time, but this link allows you to do that. And then it allows you to understand how severe your symptoms are so it can direct what laboratories and investigative tools we need. But listed in all the blue are all the different things we could potentially study when we're thinking about GI tract disease. But we decided to go pretty simple. We said we're going to try to understand, we're going to minimally burden our patients. We want to identify symptoms and try to guide care decisions at no cost. And then we're going to really focus on trying to empirically treat our patients prior to doing invasive diagnostics. We're going to empirically treat them. We're going to do bedside free, non-invasive procedures. And then we really want to try to understand what vasculopathy biology tools are out there, and try to understand how are our results changing our management plans. So that's what we set out to do. We said, similar to the skin, we use nail fold microscopy. Why don't we look underneath the tongue? And we actually had already described that there's early, moderate, and late findings of fibrosis that occur. And can we use the sublingual quantitative approach to estimate how well blood is getting into the blood vessels, so how much vascular density is there. And more importantly, this tool gave us a functional estimate of the glycocalyx. And again, our flow meter dilation told us that shear rate stress was important. The shear rate is occurring at this layer between the blood cells and the blood vessel wall. If we have an estimate of health, perhaps that can help us dissect out what is important to our patient's vascular biology of the GI tract. And in fact, what we saw is patients that had thicker frenulums, or these changes of fibrosis under the tongue, had more severe GI tract scores. And we also found that in our systemic sclerosis patients compared to healthy controls, we had a decrease in microvascular density, similar as you would expect with nail fold video capillaroscopy. And this was occurring at all the blood vessel segments. So again, really speaking to that vascular biology, or trying to understand the endothelial cell layer in small, medium, and large vessels in our scleroderma patients to understand functionally how can we improve health. So we now have a symptomatic monitoring approach that can quantify vasculopathy. We decided then to correlate that to GI tract patient-reported outcomes, and again, collecting patient-reported outcomes in the clinic while they were waiting, and then getting a movie frame of each different patient's underneath their tongue, quantifying how many red cells are located in their different vessels, and estimating that glycocalyx health, again, where the shear is occurring at the blood vessel wall. And this was really quite interesting, because our positive variable for our patient-reported outcomes was in the domains of reflux and constipation. And you may say, well, why is that so important? Because these are actually the two areas that rheumatologists are most comfortable in empirically giving treatments. And so someone with quite a bit of fecal soilage or diarrhea, or that are having a significant impact to social functional well-being, these are the patients that are being referred off to gastroenterology. Reflux and constipation, rheumatologists were more comfortable just treating this manifestation of disease. So we said, this is really actually a diagnostic tool for us to try to understand reflux constipation, and perhaps what these different symptoms are correlating to from a vascular biology standpoint. And so again, perfusion and glycocalyx or vascular health. So we moved from a universal vascular lesion, knowing that there's a functional lesion, and now knowing that function's improving perfusion and the glycocalyx is impacted as a manifestation of functional abnormalities. So let's move even further, like we did with the skin. Well, for this, we fortunately can lean on some of the research that's presented in the field rather than our own research, because at our center, we were not doing full thickness gastric biopsy. So this goes, usually you do a submucosal biopsy for diagnostic purposes, because if you're going fully through the stomach wall, you can cause a perforation, infection, inflammation. So this is a research procedure that's a very, very valuable procedure that was done by our Italian colleagues. And what they found was that these interstitial cells of Cajal, these are the pacemakers of the gut. This is what tells the gut to move. They have nitric oxide receptors, and they were separated from the smooth muscles and the micro blood vessels. But what was even more fascinating is when you look at where they're located, in the esophagus and the stomach, they're located in the different areas in the submucosal. But in the antrum, in the colon, they're right up against the surface, so you could actually see them. Well, where do we get our vascular abnormalities in systemic sclerosis? In the antrum, in the form of gastric antral vascularctasia. So we thought this was really an important clue for trying to understand that manifestation, which previously had not really been understood, and the colon where we see those vascular angiodysplasias that bleed. So these are the two areas that laser coagulation, we go in and we do procedures and try to treat bleeding because we can actually see these by endoscopy. The other areas you cannot. So we ask the question, we take submucosal biopsies and we do computed molecular phenotyping. Can we then best understand what signals, subcellular signals, are present in our scleroderma patients? And this, of course, is a very expensive study. So we did this on a small grant, and we looked at scleroderma patients. We only had funding for 5 total patients. So we looked at sex and age-matched controls. We looked at a scleroderma patient with an SEL70 antibody with less than 2 years disease duration, a centromere patient with 5 years disease duration, and an RNA polymerase III antibody patient with 10 years disease duration. And we compared those and looked at all the molecular signaling and found that the early diffuse scleroderma patient was different in all metabolites. The computed molecular phenotyping, all of it was different than the healthy control. But when we looked across all scleroderma patients, the only molecule that was abnormal in all was arginine, which is a rate-limiting substrate for the nitric oxide synthetase. And that was abnormal in all 3 scleroderma patients. And I wanted to highlight back when we talked about supplements, L-arginine can cause vascular damage. So if the answer is not just to replace what is abnormal in blood vessels, but to then understand why is this not normal and how can we fix it? So to answer that question, we said, well, obviously we can't do repeat biopsies of the GI tract. That's invasive, expensive, and we don't even know the timing of how often you would repeat those. So we really want to understand recurrent ischemia perfusion to the gut and how it causes vascular leak, cell death, reprogramming, autoimmunity abnormalities. We really need a model that recapitulates the endothelial cell. So we looked to the inducible pluripotential stem cells, where you can then do genetic testing, functional testing, mechanism, disease, and drug testing. And if we take patients' blood cells and we reprogram them into endothelial cells, can we then look at differences between these cells to understand scleroderma? And when we looked at baseline differences between healthy and scleroderma patients, we see that there is relative differences in oxidative stress genes, which is again important because we're trying to understand what's different in endothelial cells in scleroderma patients versus those healthy controls. Well, of interest, you can't just look at the cells, you have to test them. And so we grew these on electrical cell substrate impedance sensing, or ESIS probes, and we can measure the electric current between inducible pluripotential stem cells from scleroderma patients and healthy controls. And when we did that, the inducible pluripotential endothelial cells looked similar between test cells, which are human brain microvascular endothelial cells. So they stained and acted the same. So it wasn't, you have oxidative stress gene abnormalities at baseline, but those don't seem to be different between other cell types. And then when we look at the inducible pluripotential stem cells between healthy controls and scleroderma patients, similarly, they're acting the same just at baseline. Even though they have the potential to be different, no significant. What if we do something different to these cells? And if we think about how scleroderma propagates, the 2 different things we'd want to understand is, how about it if we put inflammatory molecules onto these cells? Well, when we used interleukin-1 beta, our scleroderma cells became very leaky. And if we injured the cells, if we electrically wounded them, scleroderma cells, endothelial cells moved faster. So if they're leaky and faster in repair, understanding that why that occurs in scleroderma is our next step. And that was a significant difference that we are pursuing with additional experiments to understand why do endothelial cells in scleroderma functionally act different and respond differently to different injury and inflammatory experiments. So if we have that information that they're abnormal, how should we expand our care team? So as a rheumatologist, we're good at assessing the skin, muscles, joints, and interpreting lab assessments. I like to highlight the importance of a platform for patients called Patient Care Movement. This is an online program at patientcaremovement.org that can allow you to move and exercise and ensure that you're assessing how well you're perfusing your skin and muscle with natural exercise. I always say that the cheapest, easiest thing to get blood flow to your skin and muscles is movement. And Rachel Lando started this, and she's an amazing advocate for scleroderma. So I'd like to draw your attention to her website. For patients with pulmonary involvement, movement can be achieved through pulmonary rehabilitation. And make sure if you have interstitial lung disease that you've completed this program. It teaches you how to exercise and get your oxygen up to where it needs to be to allow you to do this safely. Also, though, we found that antioxidant diets and a focus on nutrition may have a role, and so meeting with your gastroenterologist and nutritionist in addition to getting your standard studies becomes important. And so making sure that you understand what diets are safe and healthy for you is important. And lastly, ancillary services such as wound care, occupational therapy, and social work have been incredibly valuable for keeping fingers moving and making sure we're getting adequate oxygenation and healing to fingers, especially when they're ulcerated. But I hope I've convinced you that scleroderma clinical programs really do need to diagnose scleroderma early. We need to actively screen and monitor for vascular and organ involvement. We need to give therapeutics appropriately and monitor how those interventions prevent disease progression. But we also need to work with other centers doing the same and establish scleroderma and monitor how our therapeutics are affecting activity and prognosis. And so I'd like to highlight this collaborative research program called the Collaborative National Quality Efficacy Registry, sponsored by the Scleroderma Research Foundation, that enrolls patients in the first 5 years of their non-Raynaud's disease manifestation. And if you're listening to this and you qualify, these are the active centers that are enrolling, and I would really encourage you to reach out to the centers because we're eager to learn how our therapeutics prevent fibrosis, and we can't do that unless we have early disease. So in summary, I'd like to thank you for listening to me as I discuss vascular assessment and treatment and why it's so critical for scleroderma care. I'd like to kind of highlight through my own research that digital ulcer and gastrointestinal tract symptoms are really important for research into that vascular progression and treatment response, that vascular biology. We can learn a lot by understanding how to prevent ulcers, how to prevent gastrointestinal symptoms causing damage, and then highlight that multidisciplinary collaboration for patient management and research is really essential in systemic sclerosis. And I really want to thank the Scleroderma Research Foundation for being leaders in trying to bring discovery forward, particularly with the CONQUER registry. I also always thank my patients, caregiver, and advocates that participate in our experiments and advocate for research dollars to go into research. My team at the Utah Vascular Research Lab, who did all the experiments I presented, and my systemic sclerosis collaborators that helped us develop the original national database that morphed into CONQUER, and of course my funding sources. So with that, I am going to conclude, and we have about 10 minutes for questions. Thank you so much.
Well, thank you, Tracy. That was an amazing and very comprehensive overview of the vascular biology in scleroderma. We actually have a number of questions that have already been posed. And to the audience, please go ahead and add questions as they come to your mind. But I'll start with some of the ones that have already been posed that I think extend what has already been talked about so far. And this, a bit of a general question, which is, how do you think about treating digital ulcers? What's your sort of reflex medication, and what is the time course typically for resolution of an ulcer, and how do you think about that as you advise your patients?
Great question. And I want to start by thanking you for the invitation to be here today. I love this question because I think the most important aspect of a digital ulcer is prompt recognition and prompt treatment. So if a patient has a digital ulcer, those are patients I want to call me that day so that we can make sure we're moving on to a treatment plan pretty rapidly. I think one of the key things that came out of our European guidelines is once you have a digital ulcer, a calcium channel blocker is not enough. So you've automatically escalated to either combination therapy of a calcium channel blocker with a phosphodiesterase inhibitor, and those are the sildenafil, tadalafil medications, or that can be a monotherapy. So you stop the calcium channel blocker and you start the sildenafil, tadalafil right away. And those medications, just remember, you need to kind of up titrate them to make sure that they're tolerated. And I think that's kind of a common error. Either they're added on to the calcium channel blocker, people get really swollen legs and puffy hands, and that swelling can actually impede healing. So you want to sort of up titrate quickly, but in a measured way, making sure side effects are dealt with. And then immediately what we like to do is get a patient plugged into wound care. And I know a lot of patients say, they know how to manage ulcers at home, but it's worth having a wound care center sort of immediately involved. And that's really threefold. The first is, of course, looking for infection. Ulcer won't heal. To answer your timeline question, if something is infected, it will not heal at all. So it's really important that it's confirmed that it's not infected. And then secondly, they can use some dressings that can help with healing. And that wound should be looked at weekly until it's healed. Your timeline question is really good because if the ulcer is caught promptly, you can have healing within a couple of weeks. If an ulcer is either infected or not adequately vasodilated promptly, that can last through a winter. So it's really important, early therapeutics, combination therapy, and dressings and wound care being all part of that management plan.
Thank you. Just a couple follow-up questions on that as I think about it. Maybe just we should clarify for the audience what you mean by up titration, just very briefly. Yep.
Yep, and I apologize for that. I try to do better about not using medical terminology. Up titration means you start on the lowest dose possible that has shown efficacy, and then you increase that dose over the course of either days to weeks to make sure that the side effects, if you start at a really high dose of a medication, sometimes the side effects are so bothersome that the patient just stops the drug. But if you start at a really low dose and you take it up slowly, you can find the sweet spot of tolerating the medication and be able to keep a patient that may be on a theoretically lower dose than that's published, but is well tolerated.
Right. And so just for the audience, you'll end up perhaps different patients will of course then find their dose, if you will, for sildenafil, which could be different than another patient just down the road. Is that the way to think about it?
Absolutely. And that's where I always say there's caution in, I think online support groups are so fantastic, but the one caution is if someone says, oh, you're on that dose, you should be on a much higher dose. Make sure you always talk to your physician before you increase the dose. And there's variable doses reported in the literature when it comes to vasodilators for digital ulcers. So the audience should be aware that a lot of the clinical trials were negative. And so we don't have the greatest data on the optimal dose for a lot of the medications that we use.
Fantastic. And just maybe as a follow-up about the concomitant medication that you take alongside some of these other vasodilator type medications, do you typically prescribe antibiotics, and how do you feel about aspirin as a component of the regimen?
So great question. So antibiotics in general, we do not prescribe because we're pretty good about topical management. And the antibiotics, unfortunately, kind of get overused a lot, particularly with calcinotic ulcers. And so when there's a calcium debris expressed from an ulcer, remember those tend to be on the thumbs. So if those ulcers start draining calcium and the physician looking at thinks it's pus, patients get on long-term antibiotics that can cause lots of gastrointestinal problems. So we tend not to use oral antibiotics unless it is culture positive. However, topical antibiotics may play a role, and we really work closely with the wound care center to kind of understand if that's appropriate. And I also, that's a great point, topical antibiotics can have different reactions in certain patients, so they can have allergies that then make the finger to look more red. So topical antibiotics should be watched carefully, make sure you're on the right version of antibiotics. We actually use a lot of Meta-Honey, which has some antibiotic properties and is very soothing, and we use that on a lot of digital ulcers, but oral antibiotics, not really, topical antibiotics through the wound care center for certain. And then, I'm sorry, the second part of that question,
Well, just aspirin in case you think a clot may be involved. That was sort of the idea behind that question.
Yeah, and it does appear on the European guidelines. So the two guidelines that patients most commonly look at, the United Kingdom has guidelines that have been published, and there is a component if the ulcer is persistent, it's down on the algorithm, you can think about aspirin. I caution patients for two things. The first is I never use aspirin in patients that have GAVE. So if you've had gastric antrovasculartasias or colon angiodysplasia, so you've had your endoscopy and you've had any bleeding lesions, you don't want to theoretically take an aspirin because it may help cure up the ulcer. I use a lot of caparoscopy. So if I don't see a lot of microhemorrhage, which can be a sign of microthrombosis on the capillaries, I don't think there's a role, because I feel like it's one of those expert-based rather than evidence-based therapeutic recommendations. Now, if someone has an indication for aspirin because they have cardiovascular disease, that's a different story, and kind of the same thing goes. If there's GAVE or colonic dysplasias, you want to be cautious there. But aspirin for ulcers, I very, very rarely use unless I do see a lot of those microhemorrhages.
Thanks. And maybe just more on sort of the experimental side, but it's certainly being used in some centers. Do you want to just comment on how you think about IV iloprost and whether you think there's a role, particularly for patients who've got sort of more of a chronic digital ulcer sort of manifestation in their disease?
Absolutely. So, and this is always problematic to US-based patients, because the algorithms that I keep kind of referring to from the United Kingdom and from EULAR, which is our European associates, they have in both algorithms for digital ulcers using those prostacyclin analogs. And iloprost is on most formularies in the hospitals in the US. So if a patient has something called critical digital ischemia, where the finger is having an infarction, there's no blood flow, there's lots of pain, your physician may admit you to the hospital for emergent use of iloprost. Mm-hmm. However, in the outpatient setting, while on the algorithms it says this can be a consideration, that's more difficult to use in the outpatient setting. And the reason is it's not FDA approved for that indication. And so it's a very expensive drug, and physicians may not have access to it. The clinical trials were done, and so patients do chat online and say that they found it to be effective. The problem for most patients is the cost associated with this particular therapy. And I will say honestly, I think really a good vigilant approach with calcium channel blockers, phosphodiesterase inhibitors, good wound care early on. Fortunately, we very rarely need to kind of go through or access those protocols. Another thing I might point out to that point, one of the reasons we don't have access to a lot of these therapeutics in the United States, I alluded to, where they're not FDA approved. That's because a lot of the clinical trials to get these therapeutics moving forward didn't incorporate the point where there's ulcers that are not getting good blood flow. So we can give you all the vasodilators possible, but it's still the wound's not getting a lot of blood flow. And that really underscores the importance of a good topical approach. And I referenced that in the talk about amniotic membrane, so growth factor, membrane dressings that can really kind of help heal those wounds. And so that's sort of our algorithm. And again, that those prostacyclin analogs like IV iloprost just aren't very universally available for treatment because of cost.
All right, thanks. There's a couple questions, and I'll just try and wrap them into sort of more of a global question, which is, and you've mentioned it a little bit, the interaction between sort of symptoms in the GI tract and trying to resolve your trying to address some of the symptomology on the vascular side. My recollection is that for some patients, calcium channel blockers actually make their reflux worse. And so that's one issue. And we talked a little bit about GAVE and some of the issues around bleeding. So maybe you can talk a little bit about sort of things that you think about, and also maybe watch outs for patients as they try and, sort of navigate those two different sort of basically organ systems, if you will.
A fantastic question. So the way I sort of try to have patients visualize this is it's a little bit if we try to take a fire hose to water a garden flower. So we don't want to throw so much blood flow at your gut, which are tiny little vessels, or so much blood flow at your extremities, like your legs. You get lots of swelling or edema if we overdo it with vasodilators. So for the calcium channel blockers, while you'll look at those guidelines I keep referring, and they talk a lot about nifedipine, we usually start with amlodipine at a low dose, like 2.5 milligrams, and slowly increase that. Just to your point, is if you start at a really high nifedipine dose, patients get a lot of blood flow to to the base of their esophagus, causing an increase of reflux or heartburn and esophageal symptoms. And so we will want to avoid that. And so from a calcium channel blocker, the two main side effects are that reflux and lower extremity swelling. And again, that's the first line, calcium channel blockers for Raynaud's or active Raynaud's. If someone has a digital ulcer, like we talked about, you have to kind of already go to the next therapy. And that in the United States, due to cost reasons, would be a phosphodiesterase inhibitor. Mm-hmm. And same thing goes if you give that sildenafil 20 milligrams 3 times a day, and you start at that really high dose, the gut is seeing a lot of blood flow. And so it's not used to seeing that blood flow. And so it can really cause a lot of bloating, distension, bowel irregularities. And so oftentimes you'll start at that sildenafil 20 milligrams and you'll up titrate it. And tadalafil is also used, and we'll start that really low, 2.5 milligrams if someone can't tolerate a sildenafil dose, because it really does come down to giving too much blood flow to an organ that has to regulate that blood flow. And there can be a lot of symptoms in the GI tract, like bloating, distension, reflux, that comes with use of these medications. So that concept of low dose, increasing it as tolerated, becomes an important kind of treatment strategy for the ulcers, keeping in mind that the gut and actually all the organs are getting a lot of blood flow. So if headaches are an issue, change in vision, those things need to be something patients pay attention to.
Right. We have a couple questions about telangiectasias and, whether they should be treated or not. And, and if you treat them, like, what do you recommend? Maybe we should just sort of make that sort of opening and have you sort of just comment about how you think about the telangiectasia burden and what to do.
Great question. And telangiectasias are a really bothersome symptom for patients. And I think probably one of the more frustrating symptoms is that we don't have a lot of treatment options. So the way I approach telangiectasias is first, I make sure they're related to systemic sclerosis. And so just remember, there can be hereditary conditions with gene abnormalities that are associated with telangiectasias. So if a patient has scleroderma, sine scleroderma, or the scleroderma without any skin involvement and does not have Raynaud's phenomenon, those are patients that absolutely require genetic testing because they could have been labeled as scleroderma and they actually don't have it. We did quite a bit of work looking at nail-fold caparoscopy in the HHT, which is the hereditary form of this clinic, and we don't see those same dropout, big dilated loops. So that would be, something that's helpful for distinguishing between the two. The other things, just remember, cirrhosis can cause telangiectasia. So I've had a handful of patients that have primary biliary cholangitis, which causes a centromere ANA, and patients have cirrhosis from an autoimmune disease condition, but they don't have scleroderma. And those patients may present with lots of telangiectasias. And then the third is mastocytosis can have a type of skin condition. And so in patients that have atypical locations, so scleroderma telangiectasias should be face, fingers, sort of chest, those areas. If there's a lot, like sort of full body telangiectasias, lots of them all over the skin or on the lower extremities or the back, those are patients we may be more inclined to do a biopsy just to look for evidence of of mastocytosis, and you can send a serum tryptase in that case. So first approach is make sure you think it's scleroderma related, and if it is, then you move into best sort of treatment. Now, theoretically, and we've looked at large registries to try to answer this question, and we don't have a great answer to it. But theoretically, if you improve blood flow from beginning of diagnosis and consistently do that, you should have less telangiectasia burden, because the telangiectasias are a reaction from not getting adequate blood flow, and it's a healing process. So I sort of am a firm believer is every scleroderma patient should have a good vasodilator plan and a preventative approach. If there are telangiectasias present and there's lots that pop up suddenly, that patient should be reevaluated for the presence of pulmonary hypertension. So that correlation is described in the literature. And so if you haven't had your annual echocardiogram, you'd want to make sure if you're getting lots of telangiectasias that you paid attention to that. Treatment, though, tends to be mostly referral to dermatology. And so that we do use different laser-based therapies, pulse dye laser, intense pulse light laser. Those therapies are administered by dermatology and are worth a conversation with a dermatologist whether you'd qualify. Oftentimes patients shy away because of the cost. It's considered cosmetic, but it can be coded in a way, if it's put under scleroderma, that cost reduction is there. So then one final thing is green foundation makeup kind of can combine with the red to make them the telangiectasias look more like freckles on the face. So a topical option to hide them, not treat them, is an option.
Well, thank you, Dr. Frech. Fantastic, as always. Bye-bye.
Thank you so much. Bye-bye.